Welcome to this explainer. Grab your markers and pull up a fresh grid because today we are mapping out interstitial lung disease. You know, ILD isn't just one single condition. It's actually a massive, super complex group of over 200 different disorders. But they all share this one terrible thing in common. They take a healthy, highly compliant lung and gradually turn it into a stiff, scarred sponge. Whether you're a med student cramming for boards, a resident, or just totally fascinated by pulmonary pathology, this is a journey you absolutely need to understand.
So, why does a compliant lung turn into a stiff sponge, and why does it matter so much for your future patients? Well, we're going to bypass all the fluff today and dive straight into the core pathology. We really need to zoom in and look at what happens specifically in the interstitial space, that super delicate, crucial area right between the alveolar epithelium and the capillary endothelium. We're going to see exactly why an inflammatory trigger right there leads to such irreversible architectural destruction.
All right, let's kick things off with Section 1, classifying interstitial lung diseases. Let's draw out our framework on the grid here. We're going to divide these 200-plus types of ILDs into two main branches. Over on the left side, we're writing down our known triggers. These are things like occupational exposures, think asbestos, coal, or silica dust. We've also got systemic connective tissue diseases like rheumatoid arthritis or scleroderma, and drug toxicities from meds like amiodarone. Now, on the right side, we list our unknown or idiopathic causes. This is exactly where we find the idiopathic interstitial pneumonias, primarily idiopathic pulmonary fibrosis or IPF, alongside tricky conditions like sarcoidosis.
Moving right along to Section 2, the pathophysiology of fibrosis.
Now, what's really fascinating here is how an initial trigger, regardless of whether it's an inhaled occupational dust from the left side of our board or a genetic idiopathic cause from the right, sets off the exact same dysregulated, irreversible fibrotic cascade. Let's trace this pathway step by step. It all starts with Step 1, an injury to the epithelial and endothelial cells in that delicate interstitial space we talked about. This triggers Step 2, which is a completely dysregulated immune response that recruits leukocytes and macrophages. Normally, your lung would just heal this, but in ILD, we move to Step 3, the inappropriate activation of fibroblasts and myofibroblasts. They basically go into overdrive, and that leads directly to Step 4, a massive, excessive deposition of collagen. And finally, the end game, Step 5, completely irreversible alveolar destruction.
Okay, I'm mentally highlighting this next term in neon yellow because you absolutely 100% must know it for your board exams. Fibroblastic foci. Think of these as the active, buzzing construction zones of scarring in the lung. When a pathologist looks under a microscope and sees these subepithelial collections of myofibroblasts and collagen alternating with totally normal lung architecture, what we call spatial and temporal heterogeneity, they are looking at the absolute classic hallmark of the usual interstitial pneumonia, or UIP, pattern.
All right, up next is Section 3, Clinical Features and Investigation Protocols.
So let's bring this back to the patient. How does someone with these stiff, fibrotic lungs actually walk into the clinic? What are the clues that tell us this cascade is happening? Well, look out for the classic exam presentation. You're typically going to see an older patient reporting progressive exertional dyspnea, basically shortness of breath that just keeps getting worse over time, along with a persistent, hacking dry cough. And here's the clincher. When you take your stethoscope and listen closely at the lung bases, you're going to hear end inspiratory fine crackles. They sound literally exactly like Velcro being pulled apart. Oh, and don't forget to look at their hands. Digital clubbing of the fingers is a very common physical sign of this chronic hypoxic state. Now, when we send this patient for pulmonary function testing, we're looking for a very specific defect. Think about it. If the lung is super stiff and scarred, what happens to our lung volumes? Exactly, they drop like a rock. This gives us a classic restrictive deficit. This is so different from COPD. In COPD, the FEV1 to FVC ratio drops because the air just can't get out. But in ILD, the total lung capacity, FVC, and FEV1 are all symmetrically reduced. Because of that, the ratio actually stays normal, or it can even increase. Plus, because that interstitial space is literally packed full of collagen, oxygen simply can't cross over into the blood, leading to a severely decreased diffusing capacity, or DLCO.
To confirm these physiologic findings, our go-to is a high-resolution CT scan, or HRCT. Honestly, this is the absolute standard of care right now. The imaging algorithms have gotten so incredibly good that a classic HRCT scan can be entirely diagnostic on its own. This is huge because it completely spares the patient from the risks and the potential mortality associated with a surgical lung biopsy.
Let's look at some high-yield imaging contrasts you absolutely need to memorize. Breaking it down, The UIP pattern gives you that classic basilar honeycombing, which is strongly associated with idiopathic pulmonary fibrosis. On the flip side, the NSIP pattern presents with bilateral ground glass opacities, and, this is key, it actually spares the subpleural space, a finding that's highly common in connective tissue diseases. And finally, we have COP, or cryptogenic organizing pneumonia. This one gives you patchy subpleural consolidations with a really distinct feature known as the reversed halo sign.
Let's highlight one more crucial concept while we're at it: traction bronchiectasis. Now, in normal lungs, your airway walls are nicely supported by the surrounding tissue. But in ILD, as the interstitium fills with collagen and physically shrinks, it acts kind of like a network of tightly pulled strings. This fibrotic tissue literally pulls the central airways wide open from the outside, causing pathologic dilation. So when you see traction bronchiectasis on a CT scan, you know for sure you are looking at severe, stiffening fibrosis.
Let's pivot to Section 4, Treatment and Management Strategies. Okay, let's see how all this pathophysiology actually builds into our clinical decision-making. Our treatment bundles completely diverge based on the specific ILD classification we mapped out earlier. And listen up, because this is a critical divergence you will absolutely be tested on. If the HRCT shows a UIP pattern consistent with IPF, our primary medical therapy involves antifibrotics, drugs like pirfenidone or nintedanib, to slow the decline. But here is the catch. Giving immunosuppressants like prednisone to an IPF patient is actually harmful and straight up increases their mortality. However, if the patient has a connective tissue disease, like scleroderma, causing an NSIP pattern, well, in that case, steroids and immunosuppressants like mycophenolate are exactly the right treatment, because you have to target that underlying autoimmune inflammation.
Now, regardless of the underlying cause, for advanced disease across the board, we're writing up comprehensive supportive bundles. This means aggressive smoking cessation programs and pulmonary rehabilitation to maximize whatever lung function is left. Supplemental oxygen is also vital here, specifically to prevent hypoxic vasoconstriction, which directly drives pulmonary hypertension. And ultimately, for patients who meet the strict criteria, we initiate a lung transplantation evaluation. Keep in mind, this is highly prioritized for IPF patients under the lung allocation score.
Which brings us to our final section, Section 5, Complications and Disease Progression.
Unfortunately, despite our absolute best interventions, these diseases can aggressively progress. Let's trace the pathway of cardiovascular collapse. Step 1. As the parenchyma turns to scar tissue, the delicate pulmonary capillary beds are physically destroyed. Step 2. With way fewer capillaries available, pulmonary vascular resistance massively spikes. This directly drives Step 3, the development of secondary pulmonary hypertension. And finally, Step 4, the right ventricle. Remember, the right side of the heart is only used pumping against very low pressure, so it fails against this new high resistance, leading to right ventricular dysfunction and eventually cor pulmonale, which is right-sided heart failure.
But guys, the most feared complication by far, especially in IPF, is an acute exacerbation. This isn't just a gradual, slow worsening. This is a sudden, massive acceleration of lung injury that happens in under 30 days. Clinically, it mimics ARDS, and if you were to biopsy it, which we usually don't, you would see diffuse alveolar damage superimposed right over the underlying fibrosis. It is an absolutely devastating complication, carrying a mortality rate of over 85%. But let's cap off our whiteboard session today by looking to the future with some real optimism. The latest data shows that up to 45% of IPF patients carry a specific genetic mutation, the MUC5B promoter variant. Having this confers roughly a 6-fold increase in the risk of getting the disease. Which leaves us with an incredibly fascinating, provocative question. As genetic screening becomes more advanced, are we on the verge of identifying and treating this disease at the molecular level, stopping the fibrotic cascade before the very first scar is ever formed in the lung? Think about that. Keep reviewing these pathways, and I'll catch you in the next explainer.